Now, moving on to lateral condyle fractures. As I told you, we'll be discussing briefly the mechanism of injury and its pathology, clinical features, and what to see on x-rays, and how to diagnose and classify this fracture pattern, what is the treatment of the lateral condyle fractures in children, and what are associated complications. Lateral condyle, or it's actually also called as capital epiphysis, and as you remember the last mnemonic we mentioned in the last lecture, that was the critol, that is the capitulum. Actually the fusor or the ossification centers appears first at 1 to 2 years of age. It begins to ossify during the first year of life, and by 12 to 16 years it fuses completely. So between these ages, maybe you have a sheared off or a welsed off fracture by the forceful traction. So what is important is the two different classification systems. One is the Milch classification, which has two subtypes, and another is a Weiss et al. Type. If you see, this is the example of a Weiss et al. Classification, in which there is a type 1 is a fracture in which there is a cartilaginous hinge and the displacement is less than 2 mm. There is no cartilaginous hinge in type 2 and displacement between 2 to 4 mm. And in either there is more than 4 mm displacement, or there is a malrotation of the fracture fragment, which makes it type 3 injury. That is how you classify it, and we'll be discussing Milch in the next few slides as well. Now, coming to the mechanism of injury and pathology, usually the most common is child falls on the outstretched hand with the elbow extended and the elbow is forced into varus. Because in the varus, there is actually two theories. There is called a push-off theory and a pull-off theory. Now, push-off theory dictates that when the actually varus stress is applied, this results in actually the breaking off or shearing off of the lateral condyle. While the pull-off theory states that as there is extensor component attached on the lateral condyle, so when it breaks away, this extensor complex actually retracts the lateral fragment, leading to increased displacement. This is called as pull-off theory. As I told you, it pulls by the attach of the wrist extensor. So there's two mechanisms, the push and the pull, so which results in actually the lateral condyle fractures most of the time. Fracture line along the physis and it may go into the trochlea. That is how the Milch classification actually classifies lateral condyle, when the fracture line is going line is medial to the trochlea capitulum groove, or it's lateral to it. Fracture that line that exits through the capitulum trochlear groove crosses growth plate and physis and is called as Salter-Harris type 4 injury. Why? Because it is involving the physis, the epiphysis, as well as the metaphysis. It makes it type 4 injury. In severe injuries, elbow may dislocate posterior laterally in case of the high energy trauma. Condyle is capsized by the pull of the common extensor origin muscles, and it may remain dislocated while elbow reduces spontaneously. Usually when that happens, what we see is markedly displaced lateral condyle fragment, which is also malrotated most of the time. Now if you see, this is the trochlea, this is the capitulum trochlear groove. If the fracture line goes this level, there's involving the metaphysis, physis, as well as the epiphysis. But if fracture line stays over here, this is kind of a type 2 injury in which it's only the metaphysis and physis is involved. The bony fragment is usually less appreciated. Why? Because most of it is a cartilaginous shell. Therefore, when we open it up, especially during open additional tunnel fixation, we see a very large fracture fragment, which may not be very much visible on the x-rays. Displacement can be marked, and we have to look for that. It's less than 2 mm, 2 to 4 mm, or it's more than 4 mm. And for why it's sometimes more than 4 mm? Because common extensor origin is over here, and it pulls the fragment and rotates it laterally. So coming to the clinical features, what else we need to look at is the clinical features will include elbow would be swollen and deformed, tenderness over the lateral condyle, passive flexion of the wrist would be very painful, and usually the patient resists the flexion and extension of the elbow joint, and this resistance due to pain is actually an indication there is maybe an underlying fracture fragments which may be causing a lot of pain. Coming to the x-rays, mostly include AP lateral. Along with the AP and lateral views, you have something to get oblique views as well. Why? Because you have to get the full extent of the fracture, which may be missed most of the time. Milch classified according to two types. I have just discussed the Wiese et al. Classification, which subdivides into three types, but according to Milch, there are two types of lateral condyle fracture. Type 1 is the fracture that is lateral to the trochlea, that remains in the physis and the metaphysis only. Ulnohumeral joint is not involved and is stable, and this is actually called as type 2 injury. Type 2 is a fracture which crosses the capitulum trochlear groove and goes medial to it. In that of it, most commonly the elbow is unstable, ulnohumeral joint is involved at the time as well, and this is called as Salter-Harris type 4, and fragment often gross displaced and rotated. So Milch type 2 is more of a severe injury, and Milch type 1 is less severe injury most of the time. Now coming to the treatment is more of so based not on the Milch classification, but more of on the Wiese classification. As I told you, according to the Wiese et al. Classification, type 1 was either non-displaced or less than 2 mm displaced with the cartilaginous hinge intact. So if there is no displacement, then we can manage it conservatively. Arm can be splinted in back slab with elbow flexed to 90 degrees, forearm in the neutral rotation most of the time. And wrist is kept extended. This position relaxes the extensor mechanism. Otherwise, the fragment will be pulled by the common extensors. It's important to repeat the accelerator 5 days of time to see whether the fragment has been displaced or not, or there is increased displacement of the fracture as well or not. We can continue the splint for 2 weeks, and maximum we can continue it for 4 weeks, and gradually the range of motion exercises is started, and usually it heals over 4 to 6 weeks of the time. Now, if it is type 2 or type 3 according to Wiese et al., that is type 2 was complete fracture with no cartilage hinge and more than almost 2 to 4 mm of displacement, and type 3 was more than 4 mm of displacement or rotation of the fracture fragment. Then what is it? If it's displaced fracture, you need an accurate reduction and internal fixation. The reduction has to be initially closed. If moderately displaced or hinged, then we can manipulate it into position by extending the elbow, pressing upon the condyle, and fixing the fragment with percutaneous pin. That is, if it's Wiese type 2, then we have to go for close reduction internal fixation with percutaneous pins. And if it fails or it does not engage us into the place, then we have to go for open reduction internal fixation with pins as well. Now the point is, important thing is to remember is that the treatment depends upon according to the Wiese et al. Classification. Type 1 is conservative, type 2 is closed reduction internal fixation, type 3 is open reduction internal fixation. With every surgery there are always complications, and complications may be divided into early and late, and most commonly it's the non-union. It's one of the fractures of necessity, and most of the time it actually results in a non-union. It could be a malunion as well. It could be inaccurate reduction leading to a decreased range of motion at elbow, or this could lead to the elbow may be unstable and may be resulting in a recurrent dislocation around the elbow, and patient may have an unstable elbow most of the time. In this section, we have briefly gone through the lateral condyle fractures around the elbow, especially in the case of children. They usually appear at around the capitulum epiphysis appears at around 1 to 2 years of age, and it's the first to appear most of the time. And we have to closely look at the X-ray, especially when we're suspecting lateral condyle fractures. We have to see whether there are two types of classification: it's Milch type 1 and type 2, and it's Wiese et al. Classification. For practical purposes, Wiese et al. Helps dictates the treatment. Wiese et al. Type 1 is managed conservatively. Type 2 is managed with closed reduction internal fixation, and type 3 is managed with open reduction internal fixation. Thank you very much. Keep watching sqadia.com.